Hello and welcome to another edition of Signal Sleuths. My name is Ken Vitale. I'm a physician at the university and I do a lot of EMGs for orthopedics. Love to review some interesting cases, so let's get started. We are up to case number 3 in this series, and as before, we start without the clinicals, just dive right in and let you start to think of the differential diagnosis in your mind based on the data. And we have some upper extremity studies here. Ulnar dorsal cutaneous, median, and ulnar studies here. They are all normal. Feel free to pause it if you need to, but pretty darn good amplitudes here. These are the waveforms. And then a ring finger median and ulnar comparison. So we don't really have a diagnosis, right? Everything is normal so far, or within the reference value range here. We don't like to use normal ranges in EMG. We like to use reference values. That's a whole nother talk. But obviously, the electromyographer, well, yours truly in this case, is clearly looking for something. So what are we searching for, right? Based on the studies that we're doing, either an ulnar neuropathy, or someone might say, well, maybe it's a lower trunk or inferior trunk brachial plexopathy. Got it. Fair enough. Let's get some motors. And with motor, median and ulnar here, no significant amplitude drop in ulnar when we go proximally, no significant segmental conduction drop at the elbow either. Pretty good waveforms here. But clearly, did it at ADM, also did it at FDI. Someone's sniffing out an ulnar neuropathy, it seems. So this is a good time to bring up criteria for ulnar neuropathy at the elbow, right? How slow is too slow? Traditionally, and I was taught the same way, right? 10 meters per second, but it's not. If you really look at what's out there and publish, it's got to be greater than that. It's got to be at least an 11 to 15 meter per second segmental drop at the elbow compared to the forearm. That we don't see all the time, and that makes a big assumption that the forearm conduction velocity is actually normal, which many times it's not. If anyone has done EMG, we often come up with, well, low, slowed forearm conduction velocity, and that happens when those faster conducting axons get hit with ulnar neuropathy, which is a common pattern. You don't get demyelinating all the time. You're going to see a slowed conduction velocity at the forearm. A better response is checking the absolute conduction velocity, and that specific number is 48. That is used, well, commonly now, and that does not depend on a normal conducting forearm, and it actually has better sensitivity, which to me, when I first reviewed it, I said, that doesn't make sense, but it really does pan out. If you go through some studies, and this is one here, the specificity for all of these is about 95%. When you check the sensitivity, yeah, an absolute conduction at 48 to the ADM, which is, again, traditionally what many of us do. You check at abductor digiti minimi. You don't check FDI. That's probably because everyone else before you checked it that way, so that's how you learn to do it. You should probably do both. You get a better sensitivity. Another point to bring up is to bend or not to bend. Big thank you to Larry Robinson here. This is his data and pictures. If you keep a straight arm and check the conduction velocity from 2 points measured on the elbow versus that same measurement, yes, you'll get 10 here, you'll get 8 or 9 there. Conduction velocity changes big time. So please bend those elbows at least 90 degrees. Some studies even say go to 70 degrees, but 90 is usually enough. So now what do? Let's say you're in your own EMG lab. You're just trying to get through your day, get on to the next patient. You've done ulnar to ADM. You went the extra step and did ulnar to FDI, and everything checks out, right? This is not ulnar neuropathy. You've done your due diligence. Let's move on. But what if you have a high index of suspicion? There are other studies you can do. Does anyone want to hazard a guess in terms of what I did next? Well, yeah, I did inching. And here are the values here. Now, depending on the machine you have, Cadwell kind of has a preset of just 1 centimeter apart measurements. There is the argument to do 1 centimeter or 2 centimeters, and what's the normal latency in between those segments? Well, we went through and did the 1 centimeter, and amplitudes do not drop when you go proximally. The latencies were pretty much 0.1, a couple 0.2, and then one segment very clearly went right up to 0.4 within what is considered right up at the upper limits of normal in terms of latency. Aha, maybe we're onto something now. So this now brings up the discussion, not really debate, of what's the best way to diagnose ulnar neuropathy, right? We all learned to do nerve conduction to ADM. That's just the way it is, like the picture shows. That's kind of how you do it. But it's often negative. It just comes up completely normal. And well, the next step is, yeah, you got to do it at FDI. Some people are like, oh, I don't feel like doing it. That's annoying because we just never got used to doing that. I didn't. It might save you like 1 minute to only do ADM, but you add on FDI, it adds maybe 1 minute to your day. It's not that big of a deal. And sometimes if you get the electrodes right, you can just quickly switch and go. Sometimes you can do 2 channel. Do them both at the same time. Does not waste any extra time for you. I would recommend it. But what if it's still negative, like in this case, but there's some pressing clinical history, which we haven't gotten into yet, that leads you to believe that something is going on? Well, yeah, inching, that is exactly the best time to bring in your inching studies. That can take a while because you got to mark it every centimeter or every 2 centimeters. You really got to be spot on with your stimulation. And it can be, well, a longer slog through your conduction study. How far to go? Again, 2 centimeters, I would say, is a little more commonly used than 1 centimeter. I ended up doing 1 centimeter. Did I not do the right thing? Would you have done 2 centimeters? Please let me know. I would love to learn from you. And should you do an overlay or raster function, whatever the button is on your machine? Because sometimes you'll see a nice drop in those amplitudes where it might not be as apparent when you're just looking at the numbers, but the waveforms can tell a different story. And I have a slide for that in a little minute. But what if everything is still negative and you are still suspicious? Is there something else that you could do? And we'll get into that. Now, this brings up a good point. Why are we even doing inching? What's wrong with our standard 10 centimeter segment at the elbow? Is there something wrong with it? And well, yeah, there are very focal small areas of changes along the ulnar nerve that are responsible for ulnar neuropathy. And sometimes if we do inching, it is going to pick up those focal changes a lot better than a long 10 centimeter segment. FYI, if you didn't know why 10 centimeters was used, well, that comes from way back. This is now about 50 years ago. Quote unquote recommendation. It wasn't even a recommendation. It was just a measurement error calculation. They were using an EMG from the 1970s, which, yes, looks like this. That's what your recommendation is when you're using 10 centimeters, comes from this machine. And they took a Polaroid photo, put it on paper, used a metal ruler, and they were just measuring latency by hand. That is our accuracy, okay? We are not using Polaroid cameras and photosensitive paper and cathode ray tubes here. We are using digital equipment. I think we can do a better job than this. When they did this, they found that once you got to segments shorter than 10 centimeters, your measurement error using the pencil and the ruler increased to about 25% measurement error, which of course is horrible and unacceptable for a standard value or a reference value. So that's where the 10 centimeter segment came from. That's it. That's the only way we all came to follow this 10 centimeter rule. When we have ulnar neuropathy at the elbow, it is a shorter segment, often 5 millimeters, for example, and you might miss it if you use a large segment across the elbow. Newer machines, when they've done further reliability studies, you can get down to 6 centimeters before you start to get measurement errors. So with your laptops and digital machines, 6 centimeters is the new 10 centimeters compared to the cathode ray tubes and Polaroid cameras of the 1970s. If you were interested in further historical pieces, this is actually from the 1960s. I would not want to do EMG on that. And I use Cadwell. This is one of the early Cadwells from the 1980s. Man, that must have been a tough time to do EMG. We got it made right now. All right, we got a little off topic there. So inching sounds great because you can pick up those short segment abnormalities, but there are caveats with inching. And the main one is if you crank up the stimulation too much, you get, does anyone know what I'm getting at here? Yeah, it's called the virtual cathode effect. Okay, what is that? I didn't know when I was first doing EMG. I did know that the cathode is actually negative and the anode is actually positive. One attracts cations, the other attracts anions, hence the naming. And the first one depolarizes and the latter hyperpolarizes. But if you have the stimulation cranked up too much, you can actually create a virtual, so to speak, cathode along the nerve near the anode. As you turn up the stimulation, you can get a localized electric field, which alters the membrane potential, and adjacent nerve fibers nearby can actually get depolarized, and as that stimulus propagates, you can actually get multiple areas of depolarization, and well, you can mess up your latency because you're not getting a true single cathode, you're going to get an additional virtual cathode, which is why we like to keep the stimulation maybe a little farther. 2 centimeters is probably a little bit better than 1 centimeter, and don't go way super physiologic or supermax. Just get up to just barely a supermax stim, and then continue to inch or centimeter along the way. I was talking about the overlay feature. This is the slide that I wanted to show. As you start to go proximal, you get a set of waveforms, and then suddenly it drops. Here you get 1, 2, 3, and then suddenly they drop. It's subtle perhaps when you're just looking at the numbers and you see like 8.7 and then 8.5, and you might not think that's a big deal, but when the pattern emerges, this clearly looks like a case of conduction block. Sometimes the quality of the CMAP waveform just gets progressively worse and worse as you go proximally. That's another one, but here the amplitude looks like it's clearly dropping. So there is some subjective appreciation or assessment of the waveform as well in ulnar neuropathy. Okay, let's get back to our case, right? What are we missing? We've done nerve conduction to ADM. We've done nerve conduction to FDI. We've done inching studies. We had sensory studies way back in the start of this case. What are we missing? Anyone? What would you do? Would you do nerve conduction to FCU at this point? Yeah, we're clearly missing one big thing. Yeah, the EMG. And now, finally, oh, gee, there is something positive. And this really was positive. Some people say, nah, the FCU, is that really positive? This was absolutely straight up prolonged duration. I actually, measured it to make sure there were polyphagia. There's very clear increase in insertional activity. Some areas that almost looked like a little string of non-sustained positive sharp waves, but I didn't really fully call it a 1 plus because it was non-sustained. There was very clearly increased amplitude, so there's some chronicity to that. Sometimes in small muscles in the hand, you think you're seeing increased amplitude, but it's not. But when you compare it to other smaller muscles in the hand, this clearly was increased. So we finally have some positive values. Yay. So what is your diagnosis at this point, right? Would you actually call it normal, or would you start to think this is positive? Is it ulnar neuropathy? If so, we haven't talked about this. Is it at the wrist? Is it at the hand? Sorry, is it at the elbow? Um, what is going on? I'm clearly withholding some data here. Could it be both, right? We've all seen those cases. I get a lot of referrals from my orthopedic providers that want to know, well, where do we operate? Do we decompress at the elbow? Do we do a transposition? Should we go to Guillen's canal in the wrist? Should we do both? Or, Vitali, your findings are weak. This is lame. All those prior studies in nerve conduction were just completely normal. That 0.4 is still within normal limits, and your EMG findings are soft findings, right? They're not hard findings. I'm still calling this normal. And, that is true. And how about this FCU, right? How many of you have actually truly had positive findings at flexor carpi ulnaris in cases of ulnaropathy? I don't get it all that much. That's why this was kind of surprising. Like, wow, the FCU is actually positive in this case. Many times, FCU or FDP, if you do that, are very clearly solidly normal on EMG, even though those branches are coming off distal to the lesion. Some people theorize that these fascicles are in a protected area of the nerve. When people have gone through and looked at this, perhaps motor to FCU and FDP are kind of hiding in the corner or on the sides, and sensory are more exposed. There's some different pictures you can find all over the place. Maybe these are kind of hiding out in the corner, and if you get compression, you tend to get more intrinsic in the hand and sensory to the hand problems, and the stuff more proximally tend to get spared. That is what we're going with. That is this concept of fascicular sparing that a lot of people talk about. We don't really appreciate it well yet, but that's the running argument. So now what? We have some maybe soft findings, I'll give you that, but we have a patient that seems to have ulnar neuropathy symptoms. Is there anything else we would do? What would you do at this point? I chose one thing. There is still something that you can do, can be very useful in certain situations, and I'm trying to convince more and more electromyographers to do it. And if you've seen some of the prior cases, you probably know where I'm going. Yeah, I went straight to the ultrasound. And here we go. If you've Familiar with ultrasound, you'll know this. If not, here's the median nerve at the wrist, hypoechoic area there. If you look right there, that's the median nerve right there. And if we go ulnar, then we get, I kind of drew in the carpal canal here. We get the ulnar side and the ulnar neurovascular structures. Here's ulnar nerve. Here is ulnar artery. What the heck is this? This hypoechoic area sitting right above the neurovascular structure, excuse me. That is an accessory abductor digiti minimi muscle. If you track it and follow it, it'll continue right along here, go right over pisiform, and then continue down to the abductors of the hand. We do see that fairly commonly. I think about 10% of the population have it. I have never once yet seen it actually cause mass effect or compression over the ulnar nerve or artery, but sometimes we do come across it, so don't be surprised if you see that on ultrasound. Again, good information to know. In this case, it did not seem applicable. Let's move to the elbow. We have a very diminutive appearing ulnar nerve, both distally underneath the heads of the FCU and proximally in the upper arm, well above the epicondyle. If you can read that, 3.2 to 3.7 millimeters, so very small ulnar nerve to begin with. This was a rather petite patient. Okay, and we now have a video here, so if you're thinking ulnar nerve at the elbow and there's a video, you probably know what's about to happen. That hypoechoic circle in the groove going up, and there it is, right over the medial epicondyle, subluxing out of the groove with elbow flexion. There, snaps back in, and the patient does report reproduction of symptoms with it. One more time coming up, and there it goes over the groove, and there comes right back. Here are still photos of that, and on the left we have the hypoechoic cross-sectional view of the ulnar nerve, and on the right is where it subluxes out of the groove. And now we finally have the clinicals. So does the EMG data that we presented fit the clinical situation? It's nice to withhold the clinicals at first so you can just go through the data on its own and then make sure there is appropriate clinical correlation. So we have a patient. She was a about mid-30s person that lifted a heavy box 3 years ago and had ulnar volar wrist pain right in this general area here. When I asked about how the lifting mechanism happened, describes a hyperextension injury. So pulling stuff off the internet, we have hyperextension of the wrist. This would be like a Fuchs injury, falling and getting a fracture. Imagine something more like this, where the patient was lifting a heavy box, things slipped, and their wrist went into hyperextension. Flipping this picture, put in your box, that's about as savvy as I get with my PowerPoint. Other piece of the picture here is that this patient is a very avid knitter, and if anyone does any knitting, you spent a lot of time with your elbows flexed in quite a greater than 90-degree flexed position, and often leaning on your elbows as well. So, do we have Guillen's canal issues, and now do we have ulnar neuropathy at the elbow? Is this one of those rare cases where you have simultaneous issues on both segments along the same nerve? If you do knitting, and I had to inquire a little bit about this since I am not a knitter. My daughter does crochet, but you do spend some time in an ulnar deviated position with your wrist. It's not a loaded position, it's an unloaded position, but there is some degree of ulnar deviation as well. So is this starting to lean more towards the wrist issue? And is the elbow just kind of a red herring in terms of the flexing and leaning on elbows? Because a lot of us keep our elbows flexed and lean on it, and we don't necessarily get ulnar neuropathy. Here is an example of loaded ulnar deviation to further the learning. I've had a couple of cases of these where a patient was swinging usually a baseball bat more than a golf club because of the knob that's right there, and you can bang into the wrist. You can get a hamate fracture that way, but you can also get Guillen's canal inflammation in that area. She didn't have this. She wasn't swinging baseball bats or golf clubs. But interestingly enough, she said, yeah, when I really lean into that pizza cutter, I do get symptoms in my hand. That's sort of similar here. And that was a first. I haven't had that. I don't know if anyone had any case of Guillen's canal entrapment from a pizza cutter, but hey, first for everything. Also, she mentioned this we get all the time, wrist extension with yoga. That really bothers her hand. Just imagine doing a push-up or a plank and you're just pressing on it, and that is a loaded position, and that really bothered the hand. So the clinical picture is really leaning towards the wrist and not the elbow. But, we do have physical exam here, right? And if you actually go and examine the elbow, do elbow flexion maneuver, you do Tinel's at the elbow, yeah, really uncomfortable there. Is it both? Now, we do get a lot of ulnar neuropathy at the elbow here where I work. Don't get too much wrist by comparison. So that wrist, especially that injury and the hyperextension, and then just years of ulnar wrist bothering her was really, bothering me. And I wanted to, flesh that out and search a little more. And well, as you keep scanning with the ultrasound, going just a little proximal to the wrist, just beyond hamate and pisiform, going just above that, you get this anechoic area sitting right there and right there. Throw some Doppler on it, and it does not light up. This is ulnar nerve. This is ulnar artery. Same thing, ulnar nerve and artery. And yeah, what is this anechoic structure sitting there? And well, pull up the MRI. Now on MRIs, they do things in traditionally, at least at our institution, flipped over. So the dorsal wrist is here, the volar wrist is here, and a bright on T2, uh, well circumscribed rounded structure is sitting right here on the ulnar side of the wrist. If we flip this over to what we often, if you do ultrasound, associate things, when you put the ultrasound probe right down on the top, this is radial, this is ulnar, volar is at the top of the screen. Dorsal is at the bottom of the screen. So right here is your median nerve. Right there is the ulnar nerve. Right next to it is the ulnar artery. And yeah, we have a hyper-intense T2 signal, which basically has all the characteristics of a ganglion. Interestingly, it is not putting any pressure on the ulnar nerve. And if we go back to the slide here, this is the correlate here. So ulnar nerve and artery in yellow and red on the MRI, ulnar nerve and artery on the ultrasound. Well, the artery has the color flow and the nerve does not. It is nowhere near. There is no proximity. There is no direct compression. There is no mass effect on the ulnar neurovascular structures. So my conclusion to that was, yeah, maybe the hyperextension injury caused a joint issue, then eventually led to a ganglion and just some volar ulnar wrist symptoms that may have sort of given her a sense, so to speak, of paresthesias, but not true ulnar neuropathy at the wrist per se, based on the anatomical studies that we have here. But on top of that, we, well, appear to have ulnar neuropathy at the elbow. Here are other pictures just to complete the case here in coronal and sagittal. And you can see on the sagittal image that white structure is right in between two bones, so that has all the characteristics of a ganglion coming from a joint. So based on all the data, nerve conduction, there were no prolonged latency findings in terms of ulnar motor, either branch, ADM or FDI. No prolonged latency really at the wrist. There was a 0.1 change at the ring finger, which I didn't feel was statistically or clinically significant. Doesn't sound like ulnar neuropathy at the wrist based on nerve conduction. Doesn't look like ulnar neuropathy at the wrist based on EMG, but it sure does based on EMG look like ulnar neuropathy at the elbow. And then the ultrasound at the elbow, yeah, there was subluxation, got it, and it was relative enlargement given a initially diminutive ulnar nerve. It was literally double the size at the elbow. Seems to be ulnar neuropathy at the elbow. Clinically, though, gosh, it's all wrist in terms of what she's talking about, the yoga, the pizza cutter, the initial injury. It sounds like the wrist is an issue. And could there be some subclinical or prior ulnar neuropathy at the wrist at Guillen's canal from that initial injury that now when we do nerve conduction studies 3 years later, we don't see anything? Yeah, I guess so. That could be. And this is the interesting thing here. What if she has an issue at the wrist and all that pain from the injury, and now she's just doing more motion at the elbow, and now she's getting a little ulnar neuritis up at the elbow because of the hand, and there are layers of both, right? This is the difficult thing with EMG, ulnar neuropathy at the wrist, ulnar neuropathy at the elbow. They have very similar symptoms in the hand, and this is the whole fun and nuance of EMG. This is why I like to present these cases. Ultimately, the way I do things and the way a lot of electromyographers I know, we use the data to guide management, but you treat the patient, not the picture, right? Treat the patient, not the MRI. Treat the patient, not the X-ray. Treat the patient, not the EMG. So electrically, yeah, thought that the elbow was positive, but there's no axonal loss, right? There's no amplitude reduction. There's no active denervation. Doesn't necessarily need decompression or transposition surgery. Anatomically, there are issues at the elbow, but there are also clearly an issue at the wrist. Is it causing active compression now? No. Could that ganglion have been bigger and cause intermittent compression of the ulnar nerve branches? Possibly, yes. So it's good to keep uh, monitoring of both of them. Now, this is the part where I ask all of you, right? What did I do wrong? What did I mess up? What could I have done differently? I have some ideas. Could have done some more work in terms of ulnar studies. Would any of you have done ulnar motor to the FCU in this case to ferret out a little more ulnar neuropathy at the elbow? That is possible, but when you just keep on lining up ulnar study after ulnar study after ulnar study, you run out of time, right? You can only do so much. I chose to dive in with ultrasound just because I find it is quite useful in certain cases like these. And in this case, it sure did. We found an accessory abductor digit minimi, didn't put any compression. We found an obvious mass, got an MRI, and it's a ganglion. There was no mass effect this time. The ulnar nerve is relatively enlarged, double in size. 3.2 to 6.2 is significant in my mind, so that is significant. And there was subluxation with elbow flexion, which this time caused symptoms. Many times we get ulnar nerve subluxation that is asymptomatic and we don't worry about it, but this time it caused symptoms. So I felt that the ultrasound was valuable. How about the inching? Did I mess up? Did I, not do it right by doing it at 1 centimeter, and should I have done 2 centimeters? I clearly hear that argument. In fact, earlier this morning, I had another case and I did inching at 2 centimeters. So this is the fun of doing this and reviewing these cases. You try to do some improvement in your clinical processes. I didn't do the overlay feature to look a little closer for conduction block. Should I have done that? Yeah, possibly. Should I have done ulnar motor to the FCU like I talked about? Hey, what about doing FDI? So many people don't do it. They stop at ADM. My machine right now is a little bit messed up. I can't do two channel at the same time, but we're getting a new machine and I'm very excited. I'm going to certainly present some cases with the new one, and the newer ultrasound can do some two channel and then maybe increase your sensitivities that way. Here's another one. You can do ulnar sensory orthodromic and go all the way up to the elbow. Yeah, the amplitude drops down and you can certainly get motor artifact, but that's another idea. Some people do that, but it's something to consider. And lastly, what about inching across the wrist? I did not do that, and I can't remember the last time I actually did do that, but maybe I should start doing that. We might have seen some positive findings, just like we saw at the elbow, to give us more electrical backup that, yeah, there is ulnar neuropathy at the wrist and ulnar neuropathy at the elbow. I could have done that. Didn't do it. How about ultrasound inching? Could I have inched across the elbow? I kind of did. I did one at the FCU heads here, right at the elbow at the medial epicondyle there, and then proximally, but I did not inch all the way across. I scanned and did it dynamically, and it did slowly get bigger and then smaller again, but I did not measure it, and some people do that. So there's a lot of different things that you could do, but I want to know what you do. Please help me out, correct me, leave your recommendations in the comments. I would love to know how you do your EMG, and I hope to see you in the next one.